So good morning, everybody. Thank you to Mark, thank you to the board, to the foundation, and to all of you. Like Mark said, my colleague Martha Davis was on the selection committee, so I've been hearing about you for some time. And you know, I will say to Mark's opening comments, I do need to be here. I need to be here because my role at the Robert Wood Johnson Foundation is the managing director of our work in healthy communities. And I'll talk a little bit about what that means. But the Robert Wood Johnson Foundation is a national philanthropy. We are based in Princeton, and we have charged ourselves with working and in transforming local communities. My God, how do you do that as a national foundation when you are so far from the ground and from the reality of what's creating health, what's enabling health? And so for us, these are kind of our most important learning opportunities, how we learn together and how we think about what's happening in community, what's happening in neighborhoods, what's happening in schools, but also how does it play out when we think about broader policy and systems changes that need to happen kind of at every level to create the conditions that foster health and equity. So I do need to be here, and I'm really privileged and delighted to be here. Here's what I'm going to talk about, and this slide makes it seem like it's going to be a formal presentation, and I hope it's not. I hope it's really an opportunity for me to share with you not great big expertise, but the journey that we have been on at the Robert Wood Johnson Foundation, and the journey I have been on as a program officer and now a managing director there. I joined the foundation about 10 years ago. Prior to that, I worked at the health department in Philadelphia, so my background is in public health. And I will say that I have been privileged to be a part of the foundation under Jim Marks's leadership, and you got to meet Jim last night, and to really see the transformation of our foundation. Jim introduced, this culture of health vision that is new for us, new for the past couple of years. And he sort of talked about our evolution from a focus on healthcare to a focus on social determinants and increasingly a focus on equity. And so in some ways we are kind of fellow journeyers with you on this. And so what I want to do is just talk with you about what we've done, what we've learned, the tension points that we have encountered and what we still feel, and what we're hearing and learning from communities across the country, because that's also the unique opportunity we have as a national foundation, is to say, well, this is happening over here, this is really interesting, worth paying attention to, this is what they're trying over here, and we see ourselves as being a broker and a connector in that way. I'm going to talk a little bit about our approach to strategy. When I came to the Robert Wood Johnson Foundation, like I said, I had a background in public health. I had no background or context for philanthropy. So, I did a lot of research. Okay, what does it mean to work for a grant-making organization? I knew the content area, but I didn't know what that meant. And, well, clearly it meant making grants. When I got to the foundation, they were very clear. We are not a grant-making organization. My mind was completely blown. I was terribly confused because I did all the research on the grant-making. We're a social change organization, and grant-making is one of our tools. We have other tools. We can convene. We can convene people that normally wouldn't come together. We can connect. We can use communications. We can use our brand. We can think about advocacy. And most importantly, we can take the long view. We don't have to worry about the churn of the election cycle. We don't have to worry about our shareholders. We can take the long view. And so that really, is part of who we are. Grant making is a piece of it. It's an important piece, but it's certainly not the only piece. And it's changing the way that we think about strategy. So we'll talk a little bit about that. And then I'll share with you some of the opportunities we see for the future. So here is just a picture of our building. It's a lovely building. Jim, I didn't have anything else for the slide and I needed a picture. We're based in Princeton. We do about $450 million in grants annually. We're focused domestically. And I think I've given you a little bit of a sense of who we are. I want to start with this notion of building a culture of health in America, because that's who we are right now. That is our vision. It was a vision that was introduced a couple years ago. Jim gave you the rationale that we turned 40 and we said, okay, What have we done? Who do we need to be? And this was sort of the concept that was introduced. And those of you that have worked in organizations that rebrand, that strategize, have those moments of like, wow, that's great. That's a big vision. And then you're kind of walking down the hallway and you're like, what does it mean? What does it mean? And our grantees and partners, they were really trying to figure out what it meant, because it was the tea leaves of like, well, what are you going to fund? How do you fund that? And it was interesting. The same time that we introduced this concept, it was 2014. Okay, what is a culture of health? Merriam-Webster's dictionary put out culture, word of the year, because it had this broad resonance. It could mean so many things. It could mean arts. It could mean music. It could mean our history, our heritage. It could mean food. It meant the way we do things, the ways that we interact with our families and our communities and who we are, the way that we gave meaning. And we saw health in that. We see health in what we care about, what we as individuals, as societies, as communities, what we prioritize, how we relate to one another. To people who are like us, to people who are not like us. What we value and how we value health and well-being. And this one resonates with me because I am the managing director for our Healthy Communities work, building communities with spaces that bring people together. We have a long history of, working in childhood obesity. And, as we started to move more into the social determinants, we had this ongoing fight with our communications staff. Because every time we would put out an opportunity that was really trying to draw attention to social determinants, they wanted to do farmers markets and bike paths, right? And these were the hallmarks of our childhood obesity team, because that's what they were doing. We're like, no, we need to get the social determinants. And it's funny, in hindsight, what we've realized is that is about healthy eating. It is about active living, but it's about bringing people together. And that sense of connectivity, that sense of community, in and of itself is a very powerful social determinant. And so how we think about building communities, how we think about spaces that bring people together, and how we intentionally build and design places to do that is certainly going well beyond just promoting healthy eating and active living, as important as that is. So Healthy Communities, just to give you some context, is one of the 4 thematic areas of the foundation. When we reorganized, we tried to look for big thematic areas to kind of get us out of our silos and help us, better see connections in our work. It's one of 4. Like I said, we have a focus on healthy children, healthy weight. That's our historical work in childhood obesity, the work around trauma. Jim talked about the brain science work. But one of the things that they're grappling with is, how do we create a value and a shift from caring about our children or my children to our children? And what happens when we create that shift, when we're thinking about the collective of the next generation? Leadership for Better Health, you heard about sort of that focus on multi-sector and transforming health and healthcare system, which is where our historical work on coverage, healthcare quality, transforming the public health system lives. So that gives you a little bit of sense of kind of who we are right now at this point in time. And what I want to do is sort of just say, when we introduced this culture of health concept and we said, well, what is a culture of health? One of the best sort of opportunities we had to explain it was to point to the fact that there were places that were already doing this work. We maybe came up with a fancy term in the branding, but people were already thinking this way. Communities were already acting this way. And we were well served by learning from those communities, one. We were reassured, because we felt like it represented, the momentum. And it allowed us to give an example. And so our Culture of Health Prize, which actually started as the Roadmaps to Health Prize, it was like this little side program that we said, wow, this has resonance. Let's connect it to our vision. And what I want to do, and we're going to see if it works, is show a video from one of last year's prize winners, which is Louisville, just to give you a flavor of what it looks like and sounds like.
Louisville has a long history of exploring how differences in place drive differences in how well and how long community members live.
A economic disparities in Louisville and our health disparities in Louisville correlate with one another. We have about a 16-year life expectancy gap between the lowest income areas in our city and the highest income areas in our city.
The difference between what it's like to grow up in some of the neighborhoods in Louisville versus others is just stark. We recognize that in order for us to be a more compassionate city, we have to address those things head on. We have to face the history that brought us here.
Social determinants like education, like poverty level, those are all going to ultimately impact your health. And I, as a health plan, need to pay attention to that. And we can't do it alone. We have to lock arms and move forward together.
In Jesus' name I do pray. Amen.
And the whole idea behind the Peace Walks is just taking time to get out of our offices and get to meet people who live in this community, the people we serve. I think addressing the root causes of violence is huge. I mean, if we are not addressing the pervasive poverty that we see in this community, it's going to continue to contribute to the crime problems that we're dealing with.
To be able to come out and partner with our clergy, our community leaders, our kids is so powerful, and it sends the message that we're all in this together.
The mission of Youth Build Louisville is to champion young people to be great citizens as they create sustainable communities and productive lives. What we're attempting to do is to work together to build a future in their own minds and then actually build the skills they need to create that future for themselves.
Ideas X Lab is an organization that trains artists and other cultural producers as social entrepreneurs. And the mission that we train them for is to create equitable places and to nurture healthy people. Artists have always been there at the forefront of social change, and we believe that the culture of health movement is another moment for artists to step up and take a position as a change maker.
Roots and Wings is made up of various art forms, and so we have poets, spoken word artists, dancers, musicians, and a DJ. As we put this new narrative into the public sphere, the issues that go along with that, when we talk about race, we talk about economic issues, political issues, power and voice, and we think it will ignite a new conversation.
Our goal as a community is to be a place where everyone has the opportunity to reach their full potential. Everyone has the opportunity to thrive.
So one of the things, and I could say a lot of things that are exciting about Louisville, what's happening there, but we have now almost 30 winners. They all look different. They're taking on different priorities. They have different partners at the table depending on what they're taking on. And so it kind of reminds us that it's not our agenda, it's the agenda of those communities and the needs that they have and looking at all the different ways that they're addressing health and equity. Across the prize winners, and some of this is, purely reflective of the criteria. What we see is, that focus on social determinants, policy systems change, priority on equity, multi-sector leadership, leveraging, assets that exist, and using data. And a couple of anecdotal things that I will say that really separates, those communities that rise, to this sort of kind of point of recognition versus those that are earlier in the journey is the application comes from the community. And you read the application and it's hard to figure out who is doing what because there are so many partners and so many moving pieces and it's well coordinated, but it aligns with this bigger vision versus the single organization that says, this is what we're doing and isn't it great? And we really differentiate that because when the leader in that single organization goes away, what happens to the momentum? But when you have a community that has taken that on and it's embedded in their policies and their culture and their norms, harder to lose that momentum. And when that is driven by the community, there's that sense of accountability. And I think that's the other place where we see a differential is that what equity means. We get some applications where folks will recognize, we have poor health, we have poverty, we've recognized it. Or here are the services and the programs that we're going to provide to those populations. Fundamentally different than those that say, we are working with the community. We're working with those and listening and bringing those that are facing the biggest barriers to better health to the table, and really asking the question of, what are the needs? What are the solutions that we create together? And that for us is a differential in those applications. The prize is, again, one of several kind of entrees for us in understanding, in talking about, in learning about social determinants and equity. And I'll touch on a couple in this context. On the left here, you see our first commission report, which I'll talk about. The CDC Pyramid, which is really just a recognition of the building evidence base around the importance of social determinants. Our programs like county health rankings. And then what becomes a shift in the more current years is not just around the awareness around social determinants, but a real push to begin to operationalize. We get a lot of nodding heads. People get it. People conceptually understand, but they come to us and they're like, what do we do? You know, how do we actually make this change? And especially as a health funder, kind of what is our role in addressing poverty, challenges in education, structural racism? How do we think about what our role is as a health leader? I would be remiss if I didn't sort of acknowledge that this concept isn't terribly new. This is the World Health Organization definition on health that we often go back to as a touchstone. It was adopted in 1948. Health is a state of complete mental, physical, social well-being, not just the absence of disease. And again, emphasizing that focus on well-being that Jim talked about last night. Beginning in the 1990s, and I'm not going to talk about these in depth, I'll just point them out and say it's there. A number of conceptual models and evidence around this is not just genetics, it's not just health behaviors, it's how the places where we live, policies influence those behaviors in ways that both influence our behaviors and also begin to sort of affect our biology, and that's all the research around stress and stress early in life. So a number of, again, conceptual models, you'll have these as a reference. We began to sort of interpret that with the commission. And I think what's notable about the commission was this is our role as a convener. Bringing together sort of vast differences in ideology and discipline, leaders to listen to what was happening in the field, to look at the evidence, and help make recommendations on what does addressing health outside of healthcare look like. This was in 2009. And starting to kind of create that narrative and showing the interconnectivity between education, length of life, quality of life, how sort of where you live influences the opportunity to education to begin with, what that means in terms of income opportunity. So just showing those linkages. It was the first time that we previewed this map. And I would say, in addition to the synthesis of the evidence, what became really important for us was not just putting out public health data in the ways that we had always put out public health data in the table and, it's really important, so everybody's going to pay attention to it. It was a recognition we needed to put it into a frame that people resonated with. And these subway maps, people got it. People saw, differences in 7, 8 years of length of life based on what subway stop you got off. I know Steve Wolf, who's talking today, has done Richmond, and you're looking at 20 years of difference between what's happening in the city and the outer suburbs. New Orleans, 30-year difference in life expectancy. It shocks people, and it reframes the conversation. So we had done a lot of message testing. Zip code more important than genetic code, live, learn, work, and play. Different ways to kind of connote this concept. And that for us has been a really important part of our investment. One of the other sort of important investments that we made in helping folks understand and think about how to make the social determinants actionable is with our partners at the University of Wisconsin with the county health rankings. Are folks familiar with the rankings? Okay, some nodding heads. We've been doing this for the past 8 years with them. And they every year put out 50 state reports that rank the overall health of every county by state. So this is a look at Virginia. Richmond is striking. Someone sort of made that donut reference last night, where you see this, sort of dark green, kind of falling at the bottom quadrant as it relates to health outcomes in the city. And then you see that outer ring of very healthy, overall healthy counties. Ranking gets attention, so it's one of the reasons that we rank. The media loves it. And what it does, it brings attention to this model. Again, based on the evidence, this model looks at, well, what actually contributes to health? Length of life, quality of life, that's your health outcomes, but buckets down the determinants. Health behaviors, clinical care, social and economic factors like education, employment, and physical environment. And what happened was we had places like, the mayor in Kansas City, Kansas, saying, we can't be at the bottom. We have the best healthcare institutions in the state, in our county. And then what you're talking about is, well, that only gets you so far. Health is not driven by healthcare. It's driven by these other factors. And so this has become a really important tool for us in changing the frame and changing the narrative around what drives health. And there's the data to go with it. I don't want to spend too much more time on this, only to say communities kind of saw this and said, well, what do we do? We know a lot about what to do. There are a lot of technical solutions, and there are databases with the evidence about what works. But what increasingly has become clear is that these are adaptive problems. It's how communities implement those solutions, how they prioritize their resources, how they work together. And so the University of Wisconsin, with many other partners, has begun to aggregate the best practices, both in sort of those technical, what are the policies, practices, but what are the steps? How do we use data to define priorities and so forth? Like I said, this is the CDC Pyramid that looks at factors that affect health. It's very similar in nature, but it really emphasizes smaller impact, largest impact as related to influencing the community's health overall, that population health approach. And so the largest impact comes from changing the context, the environment, the things that influence people's decisions or opportunities to make healthy choices, access to healthy food, access to safe places to play, access to opportunity. And then those social economic factors, poverty, education, housing, inequality. And again, so to go back to this question of, well, how do we as a health funder think about interacting with these big, what seemingly intractable problems? And we've taken a couple of steps, sort of a couple of approaches that I'll just touch on briefly. One is around health impact assessment. I don't know if anyone's heard around health impact assessment. We have a partnership with Pew. And you see on the map, these are communities and cities around the country that have used this methodology of bringing a consideration of health into decisions that are being made around new housing development, planning, transportation planning. What happens when you bring people to the meeting to say, well, we're not going to put a stop in your neighborhood? And the community says, well, if you don't put a stop here in our neighborhood, we're not going to have access to jobs. We're not going to have access to the same opportunities. We don't have access to cars. And so it's a way to facilitate that conversation with the community. There's a real focus on equity, but it brings health and it brings equity to these decisions that are being made. Increasingly, we've been able to look across health impact assessments that have been done in planning or in housing and to say, okay, well, what matters to planning around health? How do you build health in? And so there's a lot of information that's out there for those that are really thinking about how do we build health consideration into our agencies, into our decision making. The other is partnership, because health alone is not going to solve any of these problems by itself, certainly. And for us, after we released that first commission report, little did we know that the community development sector and the Federal Reserve were starting to talk about the implications. And there was a meeting where they mashed up these two maps, and it's LA County. You can't see anything, but that's almost besides the point. What you see are two maps that look really similar. On the left is one around economic hardship, and the other is around prevalence of childhood obesity. They're the same neighborhoods. So our public health leaders and the community development leaders are saying, we're working in the same neighborhoods. And if you bring in the education folks or you bring in folks that are thinking about child welfare, it's the same neighborhoods. So how do we think about working together differently? And that for us, that partnership has really become transformative. Transformative to the point of folks saying, okay, well, we get it, how do we work together? And so that's when we brought the commission back together in 2014 to say, okay, there was resonance with those initial recommendations, resonance with the concept of social determinants, but folks want more actionable recommendations. We reconvened them. The report was time to act. Like we conceptually, we agree, what do we do? And these were their 3 recommendations. One, prioritizing investment in America's youngest children. The second was fundamentally change how we revitalize neighborhoods, integrating health into community development. And we had actually, said this is bubbling up, these 2 areas. And they came back to us and said, you've told us to look at health outside of healthcare, but actually healthcare still has a really important and fundamental role in thinking about the social determinants as it relates to the integration of medical care and social services, as it relates to the opportunity for healthcare institutions as anchor institutions with all of the heft of their real estate, with all of the heft of their investment, the heft of their employment, to actually inform the shape of the community environment. And so those were the nature of their recommendations. And we at the foundation really honed in on that second recommendation. These were recommendations for the nation, but we said we want to hone in on this and we want to think about how we begin to kind of operationalize. These were the specifics under there. And just to put in context a couple of the programmatic decisions and investments that we made. Sort of that notion of support and speed the integration of finance, health, and community development. That was the rationale for our work in Invest Health, of which Richmond is a part of that 50-city cohort. The second was establish incentives and performance measures, and we've been working actually with the University of Virginia and U.S. Green Building Council on how do you bring health metrics into a certification like LEED, into a certification like green building. So it's built in that you kind of force that consideration of health as those decisions get made. And then also the replicating promising and integrated models. We have a partnership with the Urban Land Institute on healthy corridors. Which is, again, very replicable. And then the Build Healthy Places Network is a platform we use to really elevate what's already happening in communities, to elevate those best practices, those best examples. How am I doing on time?
That time's it. You've got like 25 minutes.
Okay. I want to make sure there's time for questions, but let me talk on this. This is, as we got serious about that question, what is a culture of health? Our research evaluation and learning unit was charged with creating a framework for how we would measure a culture of health. And they, with partners at RAND, came up with a framework that on the outside you see, equity is a driving force. And the outcome is improved population health, well-being, and equity. And that there are these 4 big areas, action areas, where we need to focus if we want to get to that outcome. The first is making health a shared value. The second is fostering cross-sector collaboration to improve well-being. The third is creating healthier, more equitable communities. And the fourth is strengthening integration of health services and systems. Now, under each of these action areas, there are domains. I'm going to show 2 examples here because it helps think about what are the levers that we can pull in addressing these action areas. So for this making health a shared value, it's talking about how do we shift mindsets and expectations, right? So even that county health rankings model, how do you get people to shift beyond thinking health is healthcare, that health is really about all these social determinants? How do we shift that thinking? Civic engagement, again, that's one of the cross-cutting themes we see in those prize-winning communities, and that notion of sense of community. What brings people together that they feel connected to their neighbors, that sense of individual agency, but also collective of agency. This is action area 3, which is creating healthier, more equitable communities. And the drivers there are sort of the built environment, those safe, affordable environments that support well-being, the social and economic environment, public resources, economic opportunity for everyone, and then policy and governance, policies that create healthy environments through collaboration, sort of that health impact assessment kind of thinking. How do you consider health in that process? So just last week, the National Academy of Medicine put out a report on equity. Jim mentioned it last night. It's worth looking at. It brings, I think, a lot of legitimacy and heft and credibility to the focus on equity. And it is very much built on that action frame model. And in the middle, it's that focus on healthier, more equitable communities. It has those action areas built around it. Health is a shared value, multi-sector collaboration, increasing community capacity, and those various social determinants. The report also, really calls out structural inequities and biases, social and economic political drivers as influencing the health of our community in a way that I don't know that any of our reports have so explicitly. Just to give you some of the top takeaways, not a surprise, health equity is critical to the well-being and vibrancy of a community, and we'll come back to that framing. Social inequities matter more than health care. Health equity holds benefits for the entire nation, from economic vitality to national security, and communities have the power to take steps forward. And I think this is something that we feel and hold to be quite important. The recommendation, before I get to the recommendations, I wanted to include the slide because it's referenced in the report. We reference it often, and it goes to this notion of framing. More than 70% of 17 to 24-year-olds are ineligible to serve in the military because they are too fat. They don't meet those requirements because they haven't met the education requirements in completing high school, or they're kind of in the justice system. They have criminal records, and so that makes them ineligible to serve in our military. And we have partners that we've been working with, generals that come out and say this then creates a national security problem. We can talk about this in terms of the vitality and the productivity of our workforce. So it's just, I would say it's a tension point for us, and it's an important reminder about, just framing equity as the right thing to do might not be enough, and that we need to be thoughtful, and in this case, bring new partners and perspectives to the conversation to talk about the implications of this reality. Some conclusions: health inequities are in large part a result of poverty, structural racism, and discrimination. Communities have the agency to make change, that there needs to be supportive public and private policies at all levels. And this other one, that tools and resources exist to translate the knowledge into action. Again, sort of making the case that it's not necessarily a technical fix, it's that more adaptive, how do we create these solutions and implement them in our communities? So this is, like Jim said, hot off the presses. It's a brand new report. It's worth taking a look at and following how we all collectively respond to those recommendations. Just a couple of points on how we are thinking about strategy. We have adopted this framework of emergent strategy. And if you know philanthropy, you know we like buzzwords. And so we recreate sort of common practices with new framing. And this is the framing of the day. So it's basically how to do good strategy. But it helps, especially for our program staff that are focused on doing really good programs and wanting to make sure they do really good grant making, to kind of get their head up and see that these are systems level changes. And it kind of talks about, okay, how do we deal with complexity, or what is complexity? What are the types of challenges that we're dealing with? Are they simple, like baking a cake? We just need to follow the recipe. Are they complicated? Sending a rocket to the moon, it's really hard, but if you got the sort of right smart people in the room, there are kind of ways that you put it together. Or are they complex, like raising a child, where you have to deal with all of these external influences that are going to interact. And most of the work that we're dealing with probably fall into that category. These are complex challenges that we're dealing, and thus we need to be thinking about the complexity of systems. So we've spent a lot of time learning, engaging our staff in learning about, what are systems, and if you want to influence a system, how do you take these factors into consideration? And so just some of the tactics that we're using, thinking about how we can better see the system, and some of that means we're talking to people to understand, to get their take on the challenge, the opportunity, to see it from different vantage points. That we can't stay static in our strategy, that we can't say, this is our goal, this is how we're going to do it, we've got a 10-year goal, and we're not going to look up, right? We need to keep looking up. We need to look up. We need to figure out, okay, how do we adjust? What's working? How do we accelerate that? What's not working? What changes do we need to make? And putting a compass in place to support on-the-ground course correction, which is great. What's a compass? Again, someone came up with this. It's good. But here's what a compass, and I can tell you, working with my team, it is helping us think differently. Learning questions to guide our inquiry. Not just what are we trying to do, but starting to ask questions. Okay, well, what influences that? How will we know if it's successful? Questions to guide our inquiry, and a systematic data collection and feedback loop. So periodically saying, okay, every quarter we're going to stop and just say, how's it going? And we're going to use that data collection to get a pulse, to see what are we hearing. And I can tell you that right now, given all of the changes that we're seeing at the federal level, what we'll see at the state level, this is ever more important. What are we learning? What are we hearing? What implication is it going to have? And again, this sort of cross-team reflection. And this for us means that we don't sit in a conference room by ourselves and say, what do we make of this? But we bring in others, we bring in our partners, we bring in those that are going to be affected by the decisions that are being made. So just to give you an example of kind of where we've netted, and this is our work in healthy communities, our goal is to create the conditions that allow communities and their residents to reach their best possible well-being. For us, we have a focus on catalyzing multi-sector community action in the most marginalized communities and populations. For us as a national funder, this catalyst piece is important. We're not place-based. We can't do place-based work very well. We don't know the context. We have, over the years kind of grappled with, what is our role in sort of investing more than impact investing. We think that's a really important tool. It's hard to do as a national funder because you don't know the local context. You don't know the players, but it's an important role. But we have to think of ourselves as a catalyst. And when we think about our approaches, okay, what are we good as a national foundation good at doing? It's thinking about that strategic communications, that shifting mindset and expectation, all of that messaging research. Data. We talked about county health rankings. We've made a lot of investments recently in sort of more micro areas, zip code, census tract data, because we know that's critical to getting to understanding inequity. Elevating policies and practices, this notion of leveraging financing and activating strategic partnerships and networks. And for us, that includes partnerships and networks with local funders. Right? Because again, this work that's happening here, we can't do this, but this is critical to the vision that we share. So we think about these types of partnerships as being critical. For us, some of the opportunities that we are paying attention to and kind of working on that I think are of interest, one is a focus on mid-sized cities, because we think they're a natural place for innovation, especially when you're talking about cross-sector opportunity. And also, as we've looked nationally at mid-sized cities and health outcomes, that we've seen sort of a plateau in some places, a decrease, and also kind of looking at investment. Some of the innovations in investment and community investment as it relates to health have happened in those big metros, but we think that there's an opportunity for that in mid-sized cities to be really transformative. We're also paying very close attention to what's happening in our rural communities, and that's where we're seeing life expectancy actually go down. And we have not been particularly present or effective in rural communities. So we're really focused on learning in that way. And also sort of leveraging the role of anchor institutions, specifically in the context of investment and in the context of capacity. The There are risks to that. We can talk about those risks, but we think, especially now, there's a real opportunity there. So, some key takeaways that I hope you take away from this. I am interested to hear what other questions or takeaways that you do have. If you haven't gotten that health is more than healthcare, I have not done my job. And that philanthropy is a really a social change agent. Sort of this notion that this type of work, programs, services are key. We also need policy systems and culture change to get to that transformative effort. Those things take time. That's the reality of this work. But what we know from a lot of these prize winners is we also need quick wins. How do you get people engaged? How do you show progress? It might not be, the big, audacious, we're going to deal with housing segregation this year, but here are some of the ways that we're making progress and working towards those bigger goals, something that we've seen. This sort of notion of adaptive, boundary-spanning leadership, community at the center. And we can talk more about that. For us, really this power of data and strategic communications to reframe things, to bring people to the table in a new way. And again, cities as a locus of innovation. We really see, and we are paying attention to what's happening in cities where there are opportunities to elevate, to learn from. We think that there's leadership, there's enthusiasm, and real opportunity. So I have great admiration for what you're taking on. And I thought I would share this quote. This is actually in the National Academy of Medicine report of all the forms of inequity, injustice, and healthcare is the most shocking and inhumane. And would just leave you with this. So, thank you.
So taking a cue from that quote from Dr. King, the Civil Rights Movement, and also thinking big, I'm sitting here listening to what you presented and being very validating in our work, and just speaking from a local perspective in terms of a cross-sector willingness to collaborate in terms of service provisions and implementing best practices, and even you spoke about asset building within the community as opposed to coming in. All those kinds of things are the tools and the approaches from a service provider's standpoint, right? But thinking big, and you're saying we need little wins. Yes, we do need the little wins, but how do we bring about? I mean, because I'm into like 20 years into this work, right? And experiencing incremental success. And we've all had incremental success, right? But how do we begin to integrate an approach that really, talks about using an axe as opposed to a scalpel? Just really, thinking audaciously about the issues, the pervasive issues, the root cause, the poverty, right? And the policies associated with these structures of poverty. So please don't take this as I'm attacking the foundation, but just kind of giving your national lens. What role in terms of advocacy and integrating an axe approach as opposed to, a predominantly scalpel approach to finding these incremental wins? In terms of policies, because the one that really strikes me is like the composite index in terms of how public schools are funded, right? If we can't address those pervasive policies that have just really perpetuated poverty in communities like Richmond and all across the country, we're never going to experience the change, and otherwise we're just going to continue to be Band-Aids on issues or in these communities for the next 20 years. And so I'm just sitting here like, and I didn't know this was going to really grab me this quickly. This is just the first session, so I apologize. But I'm really having, I really have an issue with, the rhetoric, and this is very validating. We all know this. I think we're preaching to the choir here. But how do we get on the other side of the table and see, kind of what's preventing us from moving forward from a policy standpoint? What's the argument to what you presented here and what we all know? So it's like policy is the enemy that we really gotta, has really got to address, and that tool that the policies are really addressing is this perpetual poverty. You know, so what role can Robert, Wood Johnson play in terms of advocacy at that level?
I'm going to give you some thoughts, but I welcome you to keep pushing yourselves and pushing us on this. Because the big answer is I don't know. I will say that we have not shied away from policy. We cut our teeth on tobacco. And we went into tobacco and started pushing clean indoor air laws and increased tobacco taxes at a time when the evidence was still early. And we've actually seen success, not all the success that we need there, and it's certainly not the foundation alone, but smoking rates have dropped dramatically since we've started to introduce those policies. I say that because there was an interplay between sort of those policies and culture. And I think we kind of are thinking about that a lot. So now, just understand people would smoke, in an airplane or smoke in a hospital. I mean, that is so culturally unacceptable at this point that there was a shift that I think was an interplay in policy and culture. And I think one of the lessons that we've drawn is, our kind of orientation historically has been, we're going to create the evidence and then we're going to drive the policy. And we're not seeing the same success. I mean, there's a question of, does the evidence resonate? And there's a link between the evidence and building demand for the policy. And that's where we're feeling truthfully, our growing pains, because we're not particularly well suited for building demand. Like, how do we do that? I think the culture of health vision was a way in sort of thinking about culture and that sort of necessary shift in values before we can start taking on policy. You just threw your hand up, so you might have something you want to add in.
As a child advocate and someone who is in the communications and messaging business, one thing that you said about that really resonated for me is that equity doesn't work to convince people because it's the right thing to do. I mean, I can tell you that doing the right thing does not work. People think they're doing the right thing regardless of what they're doing. So, to me, the biggest bridge and how we get from here to there is convincing people, and I'm looking at someone with kids, but it's not just about my kids.
Right.
It's getting people to care about all the kids. And so how we get people to buy in, I mean, doing the right thing does not work. So how do we care, is it a business argument, is it workforce? I mean, there are many different ways of going at that, but I mean, that's what we struggle with daily, is how you make that policy, is that people first have to buy into the fact that other people's kids matter.
Yeah.
Like 70% they don't qualify for the military. I mean, that wasn't new to me, and I could see how that would resonate for someone else that maybe don't see it the way that we see it.
Yeah. Let's go ahead.
I want to build on this conversation. Thank you for an amazing presentation. I'm excited to get people to be in. So I'm struck by the return on investment argument, which we have to make a different set of cases depending on who the audience is, right? This is community, this is your work, right? Because self-interest is powerful. So I think this data plus strategic messaging is an important thing for us to think about in our region, return on investment. But tied to that, so in my mind, that's how we message to the haves, right? To get engaged, write a check, bug your, city council person, figure out something. But then at the same time, you have this community center bullet that I'm really interested in because my work is civic engagement. So thinking about this continuum of engagement, we need advocacy, we need policy, we need check writing, and we also need to empower the very people in these communities that we're purporting to serve. And how do we do that in a way that recognizes their assets, builds their capacity, builds their advocacy, which could bring them into jobs and well-being. And those are two very different but equally important, right? It's like bottom up, top down, merged together. And I'm really interested in thinking about how to do both well, because they're different strategies and approaches, but we're not going to see change on the equity agenda and systems change unless we do both. And I actually think the second is much harder. Right. I mean, we're all sitting in this room talking about equity and health, and the very people that we reported for last year again, right? And no criticism, but this, I said this in May. I mean, look, I work in an elite higher education institution. I critique myself on this way all the time, but how could we make both of those projects equally weighted so that we can see top down, bottom up together? Because that's when policy will actually change. And if you have experiences elsewhere that you've seen, how centering the community works, or this return on investment, strategic communications work, we would love that.
Well, the return on investment, I mean, that's in some ways we're well suited to do that type of research and analysis. And so there's a range of different products and research that we can share, both from sort of the business perspective, but also in some of the framing for different audiences. So we can certainly stay in touch on that. The piece on, the top down, bottom up, I don't disagree. Those are both important. I think some of the interesting opportunities, and while I'm so interested in the arts work, that the arts fellows that's starting here, I think in some places, you saw it in Louisville, like there's something in that space that can bring people together. The farmers market analogy, it brings people together. We've been talking with folks, some folks that came from HUD that are kind of looking at mixed income development and mixed income communities, and sort of what do we know about what's working? I mean, these are still relatively new concepts, and the value proposition hasn't quite been made, but they're introducing concepts of like neighboring. How do you bring people together? How do you bring people together that aren't in the course of their daily life or in their Facebook news feed going to interact? And it seems like that is kind of an important opportunity that transcends that bottom up, bottom down. But this is the new piece for us. I mean, I'm not going to stand here and say I'm an expert. This sort of culture frame for us is brand new, and that's why we're so enthusiastic about learning with others. Go ahead.
It would be important, and I guess my comment to that would be that it's important for communities to kind of figure out what the right size is for them.
Yeah.
And the more that policies direct procedures, the less the community really can create their own. And I think that the more at the policy level and federal level, best practices are shared, but the program isn't designed specifically to emulate what happened in Louisville. Because I think that's where we run into a lot of problems. You have a great example, a model city that did something well, and you take out all of it. The policy and the program design takes out all of the organic elements that made that work for that community, and other communities are expected to emulate it, and it's not possible. So I think
or desirable. I mean, I think you hit on a really important lesson that we have learned, and I don't know that we have fully embraced it, but what has been exciting for us with that program is that you have 30 communities. They all look very different. I mean, we have rural, Williamson, West Virginia, and it's a whole different set of issues and a whole different set of partners. And I think I couldn't agree with you more in terms of that needing to come locally.
It seems like the policy development sometimes tries to take those good things and then codify it, and we can't do that. I guess I just suggest that maybe part of that is when you're in a position at the foundation to support policy development, preserving that ability for the community decision-making process is really critical. So, I know that there's a lot of different things like block grants and those kind of things, and that's what makes it's harder to measure at the national level, which is why it's not ideal, but it really is what works at the local level. So I don't know whether that's the space for you all to be able to inform that and organic development.
Well, I think, there are a couple things that I can say. One is, we can't lobby. So how we think about policy is also kind of shaped in that way. But we think about research. We've done a lot of research on preemption. and preemption, when laws at the state or federal level inhibit an ability of a community or a city's ability to kind of do their own policy making. So there's a lot of work there, and sort of understanding that as a sort of a practice is something that we do. We've done a lot of work on tracking block grants and what happens. And I think we could all debate the pros and cons, and there probably are pros and cons. I think, yes, the opportunity is to think about innovation and to think about what can be learned by some of those innovative practices. We also know that funding tends to get cut for those programs once they get block granted. So that is always, our job is to bring to bear kind of what we know and bring to bear the research. And there are others that will do the policy interpretation. But these aren't easy if these were easy questions, there would be easy answers. And I think the other thing that factors into this, and we think about this a lot, is equity. When we look at the country, there are states that are sort of equivalent in terms of health status to, third world countries. And, terrible health outcomes. And how do we think about the protections sort of from standing back and looking across the country? So these are sort of broad, more kind of philosophical things that we think about or that we're paying attention to in our policy making or in the research that is done. But it ultimately comes down to, policymakers and decision makers in terms of how that plays out. Go ahead.
So again, thanks for the presentation. It's really informative. A thought, and then I guess maybe a question. And the thought, I think, ties back to the idea of culture of health. And part of culture is the values that people share. And so for me, it feels like part of the conversation about how do you engage different groups, whether it's those at the top or those who have the challenges or the providers, is how do you develop a common set of values? Because I think on the surface we see that return on investment may appeal to someone, or just equity in and of itself may appeal to others. But I guess I feel that there's oftentimes common values that everyone shares that aren't at the surface. And so maybe part of the process that we have to think about is how do we bring to the top those common values that are shared across all segments of the community. There's children in every community. There's people have the desire for self-fulfillment. And that cuts across all communities. They have desire for safety. All of these things that I think are common values that maybe if we're able to have a process that pulls everyone together around that, then that helps to bridge some of the divide and some of the strategies they can whether it's policies, programs, or whatever, can tie into the values. And so I kind of have want to hear your thoughts about that, but tied into that also is the issue of racism and other forms of oppression. And you kind of referenced as well how Dr. Johnson, I think, has progressed in their view and articulation of that issue, and I think it ties into the values as well. But I guess I'm curious how you all made that transition and where you are with it, and what you think that means for Richmond and other communities and other funders as well.
So I'll take the last one, and I think it's again a recognition of kind of the reality that if we really want to kind of change the trajectory, like we have to have a conversation about why health is the way it is. And we have seen the leaders and communities out there that have had the courage to do that. And that changes, it just changes the conversation. When someone puts race on the table and says, we're going to talk about this as a community, I'm not going to suggest that it's easy, and I'm not going to even begin to suggest how to do that. But we saw that in Cambridge, Massachusetts. We saw that in Kansas City, Kansas. The work in Kansas City, they started to disaggregate their health data by race and looking at it by place. And that report that came out and said, to the community, started a community conversation. And then it began to get people to talk about, why is it this way? And they were able to talk about truths, the line, the sort of the dividing line in the city, and segregation in the city, and what the implications were for thinking about housing, redevelopment, schools. And that conversation and the willingness to have that conversation, they would say they're far from perfect, but I think it has enabled change. It has enabled people to at least put it on the table. And so I think for us, at some point, that's what the data says. I mean, the data is quite clear. And I think we can disentangle it by race, we can disentangle it by poverty. But the conversation goes to sort of, I think, what the National Academy of Medicine, points to, that we're not going to do programs and services to get our way out of this problem. And so, thinking about policies, we were very closely tracking the affirmatively furthering fair housing policy that was coming out of HUD as a promising start to kind of foster those conversations. And I think it's an opportunity for the city to say, how do we look at our data that way? I think Steve will be particularly helpful. I mean, Steve Wolf this afternoon knows the data, knows how to think about it, and can be a great resource, and how it could be used to start a conversation. Your first question was?
Values.
Values. Yeah, I mean, I think it's huge. I think it gives you a starting place, and it's sort of a question. Listen to the community. What do people care about? What do they prioritize? What does that tell you about where people want to, kind of spend their precious time and resources? What's going to get people to show up? What's going to motivate them? And how do you connect that to the needs and the opportunities and sort of the assets that exist? So, and I will say, I mean, again, we are in very much a learning mode. We are very kind of interested in the work that you're doing. We don't purport to have all of the answers. And I hope that, I'm looking at Mark and Danny and folks in the back of the room, that this can be, an exchange, that we can hear kind of where you come to, what recommendations, because I think there's certainly, transformational opportunity in the city, but I think there's a question for us. What can we do as a national funder? Not dollars, not a grant, but thinking about that policy landscape, thinking about the messaging framing, thinking about the research that you feel like you need in order to accelerate your work. What is that? And I think we would benefit and value your input on that question. So, thank you.
What's up? You run out.
Well, I don't, what time is it? I think I'm okay. I'm good.
While you were here, and while it was sort of on your minds, I mean, I don't know about you, but I just found that such a remarkable framework and just so helpful to thinking about the tasks that we all have here today, and really inspiring. This morning, we spent a lot of time kind of clarifying the task, trying to get at what it is to create an equity and health agenda for the foundation. And I wondered if anyone has had any aha moments while we're here, in terms of insights, in terms of our own tasks, like what would be helpful to be thinking about as we go along our journey.
Yeah. Please, we don't interrupt this conversation. You rock. Thank you.
Okay. Thank you.
It means a lot when you're here.
Yeah, absolutely.
Please take the question.
Okay.
I know, because now I'm stuck on you rock, which you do.
We can go out on a high note.
I mean, what I wondered about is if some of the frameworks about how Robert Wood Johnson broke down the culture of health, how it looks at policy, data, community presence, if any of that kind of spoke to you in terms of thinking about how we formulate our task or our work together. Yeah, Joyce.
I'm going to take a stab at this. One of the things that kept resonating, especially after Damon said what he said, I think we have kind of an example through Promise Neighborhoods.
Mm-hmm.
Because this organization, Robin's organization, acted as a convener, at least in my history with Richmond. That was the first time that I sat in a room with all of the major funders in Richmond, as well as the city, as well as all of the major nonprofits. parts of that are still going on. And I think, to Damon's point, in some ways that did characterize a lot of the things that we're talking about. The community did get involved, the community is still involved, jobs were created, people are working. And I was trying to figure out, like, what was the thing that didn't happen, or hasn't happened yet, perhaps? And maybe it's the unpacking, like, what happened to the process? Where are we now?
Or even just like looking at the policy, there wasn't,
And
there was
that's
sort
what
of
I'm saying, is because
right.
the driving thing was the money.
Mhm.
That's originally why we all came together, but I think it quickly became bigger than just getting that grant, or it's still going to be going on.
So it's kind of looking at some of the successful place-based or neighborhood-based stuff
Yeah.
and unpacking it, figuring out, well, what was missing? Was policy missing? Was, grassroots
Yeah.
leadership, top-down? Where can you do
Yeah.
even
I mean, that's the thing that was
more deeply?
kind of resonating with what you were saying.
Good. Yeah, any other thoughts that came up in terms of thinking about our own task, developing an agenda?
I have a couple.
Yeah.
So they're like all over the place, they're not connected. So one is thinking of the things that we're trying to approach with the East End Initiative across the city, and how we're starting to formulate a coalition to approach that problem, which sounds similar to the way that this framing is, but if you look at the people that, or the examples that you gave, where people have been, or areas have been awarded, the 31 areas of the country that have been awarded, it's like maybe they're a little bit ahead of us, and we're coming together that way now, and this framing will help us as we move forward with that.
So it's a good way to communicate, the strategic communication.
Yes. The second has nothing to do with anyone but me, which is that I look at how you presented that and how there is, Robert Wood Johnson to me does such a good job of taking very complex concepts and perhaps that's part of your job there, and making them something that everyone understands, even though there's still a huge level of complexity to it. So around the complexity approach for framing, it sounds kind of like the ideas, I think, that NIH is using around complex adaptive theory. So they're all kind of mixed in there together, but said a different way, so everything aligns. Those were my two things.
Kind of a simple educational message seems really important. And building on assets, right? Building on kind of what's in the community. Like you said, a lot of the communities had it already going on. Yeah, a few quick thoughts, and then we'll let Abbey get on their train.
It actually relates exactly to what you just said, assets. As I'm sitting here, I'm feeling a big lack of knowledge about some of the great assets that are probably already happening in the Richmond area. And I think because of that, I'm feeling hesitant to even say anything, because I'm thinking, well, we could already be doing a fabulous job of bringing these groups together. It's just not something that I know about. So some type of, and I don't want to get super in the weeds in that, but I do think it's just helpful to have a good sense of what is happening.
And we talked about the importance of sharing and networking among you, so that kind of resonates. Yeah, Amy?
I would just add to that, I think some of your graph slides, Jonathan and I have been in conversations with the multi-sector group, with the Kellogg Foundation, around it, where it's like, oh yeah, that slide and that's the same slide. So to think about the existing large-scale foundation, national foundation interplays, and the local networks that already exist, so Office of Community Wealth Building, CRC, Kellogg's Racial Healing, Racial Justice, and to be smart enough to knit together the common cause, right? It's a little bit to the values thing. I think actually shared values is really difficult, and I yearn for that. But there's common cause already happening. We're calling it different things, and we're funding it in different ways. So can we be the knitters? I just see us as knitting needles to do this, because Kellogg and it's right there. So I would like to see us do that.
Fabulous. Yeah.
I think sometimes in a small community, you have so many different groups addressing the same goal. And I know we have in my area the Downtown Churches United, which is supposed to be representatives from all the different denominations. And then we have the Petersburg Wellness Consortium.
And there's so much overlap in what they're doing, so they're almost working parallel instead of interdisciplinary or integrated. So what in a small town do you see is a way to address that gap?
The gap or the overlap?
The overlap, which is producing a gap in what they want to accomplish, because they all want to promote health, but they are in some ways working parallel to each other as opposed to working with each other. And there is some competitiveness.
Well, I mean, I think that's, I would imagine the funding streams, I don't know what they are, could contribute to some of that. So I think, in some places getting the funders, kind of involved and aligned, and then, kind of thinking about how do all of the assets that exist in the community start to kind of line up for those priorities, and folks can see how they're working either consciously in tandem or in a coordinated fashion for that shared goal. But there needs to be something or someone that brings them together, that they kind of see the opportunity, why they should think about, and what the incentive is. So I think that funding piece would probably kind of be an important part of the conversation. So
you've gotten a lot of wisdom out of the speech. That's what I wanted to bring it out, because looking at kind of all of the things that are important in thinking about a recommendation for this foundation: the communication, the community involvement, the building on the assets, the aligning and coordinating funders, the link to policy. So I think again, you're remarkable.
Thank you.
Thank you for your time.
Thank you.